And then I just have some housekeeping for you. So welcome to Webinar Wednesday. I'm Carly Endries. I'm the Outreach Coordinator for the North Dakota Brain Injury Network. So you are at Webinar Wednesdays. We do these every other Wednesday, but with a variety of topics and speakers. CEUs are available. If you would like to request CEUs, that request will go up on the same spot where you got into this webinar tomorrow. By tomorrow, that will be up along with the recording for you. So you can make your CEU request there. And then usually it just takes me a day or two to get it back to you. But we have 2 more scheduled, and then I'm working on scheduling the rest of the summer. So in 2 weeks, we have Michelle Brazant, I think is how you say it. She's a survivor that's written a book about her experience and things. And then we have BrainScope coming after, kind of a very new technology to, do you know about BrainScope? Yeah, I'm excited for them to come and show us their new technology. So, but yes, so today we have Dr. Balbir. He serves as the Director for Independent Services. Prior to joining Wounded Warrior Project, he served in the private sector as a healthcare consultant, supporting the Department of Defense, military health system, and as the Chief of Operations for Clinical Research at the National Intrepid Center of Excellence. In 2019, he was selected as a President George W. Bush Veteran Leadership Scholar. Alex serves in the United States Navy Reserve as a Medical Service Corps Officer, Hospital Healthcare Administrator. So he's just bored. He has nothing to do, right? He obtained his doctorate of philosophy in public health from the Johns Hopkins Bloomberg School of Public Health, focusing his work on sleep disorders and brain injury and post-traumatic stress. He also holds a Master's of Business Administration degree from the University of North Carolina, Ken Flagler Business School, focusing on organizational management and entrepreneurship. So thank you so much for your time today. I'll let you take it away.
Well, thank you for having me, everyone. It's good to see some faces here, and then I just see some black boxes with some names, but it's great. This is such a nice invitation. I don't get to do many of these too often and really get to dig deep into some really amazing topics with my colleagues. Sometimes I'm just, as you all know, you get caught up in the world of either working with patients or you get caught up in the world of supervising staff. So this is truly an honor. So thank you, Carly, for inviting me. What I'm going to do today is I'm going to talk to you all about, I have a presentation about that focuses primarily on military and veteran brain injury and some of the work that I've been a part of over the last 10 to 15 years, but primarily just over the last 4 years, and just our approach here. As Carly said, I'm currently a director at Wounded Warrior Project, a national organization, nonprofit that supports post 9/11 service members, really looking to honor and empower them when they transition out of the military, and afford them the opportunities for financial wellness, physical health and wellness, mental health and brain health, and really creating that social capital for them when they transition out. It's a very tough and challenging circumstance when people do separate from the military, and some do it better than others, and some have significant injuries. But I'm going to direct my talk here on the brain injury side of the military and some of the work we do here at Wounded Warrior Project. As always, please feel free to stop me, ask questions. I want to try to make this as engaging as possible. And let's kick it off. I'm going to share my screen real quickly. There we go. All right. And if you have problems hearing me or if something's wrong with one of the slides, please either raise your hand or just shout out. All right, so for today,
we are seeing your notes. I don't know if you want us to see those or not. So,
oh, you are seeing notes. Oh, that's interesting.
So you might want to just do other, I think, display settings.
Where is
up there in the middle.
Which one is it?
In the middle of the top of your screen, right above there. I think if you click on that, display settings. if you do.
Oh, wait, which one are you? So, oh, you're seeing, okay, I get it. Let me stop share here. Let's see. Are you still seeing the notes?
No, we're not seeing anything now. Now we're back to you. But yeah, if you want to go screen share
That's
again,
odd.
maybe.
I apologize.
That's okay. And we can see your notes too. I just know sometimes I'm reading stuff.
No, there's really not much in those notes.
Okay.
I just want to make it look like a clean presentation.
Usually if you go presentation mode, are you using PowerPoint?
I am, yes.
Yeah, that little presentation mode up in the corner, there's like a little, looks like a projector almost.
Okay.
That one usually.
So now,
so that's a little better, but if you click that button up on the top right, on the top left of your screen, it's to the left, up a little more. And there's kind of there you go. Yep. Oh, it's still
my
notes, but
that's odd.
It's okay.
All right. Well, I apologize. You shouldn't be seeing this
all right.
one. Actually, let me. Oh, that's gonna mess it up. Well, give me 1 second. I'll get this fixed.
There, if you hide presenter view, I bet. There.
What do you just see?
Okay.
Do you see my power?
Yes. Yeah, so if you want, you can drag your notes down so that it fills the full screen there. That's a little better. Yeah.
Yeah. I apologize. Sorry, folks.
It's okay. We're all
All right. Can you see that?
Yeah. Yes. All good.
Okay. If I can I might be able to make this bigger. Well, I've got some animations in here, so I hate this computer. So sorry, folks.
So do you see the little arrow with the line? Yeah, there. Okay.
All right. Well, we're gonna roll with this for now, and I'm gonna.
Yeah, you're all good.
All right. Okay. So I'm going to focus our discussion today on, four different topics here. I'm going to give just an overview on brain injury with a focus on military. I'll move into some novel clinical approaches that we're looking at. And we've currently partnered with some really amazing organizations to execute some of these clinical strategies for traumatic brain injury. And I'll also talk about our home and community-based programming as well. And then we'll end this with another partnership that we have here at Wounded Warrior Project that really focuses on the research advocacy side, and I'll speak briefly as well as about policy. I think we all know that without policy, we really don't get an opportunity to take advantage of all the great research, all the great clinical care. It's really truly getting to a policy level for treatment of brain injury is the most critical element of what we do. And that's really sort of the end product of a lot of the work that we do with our partners in the clinical space, as well as our organization, Wounded Warrior Project. So this is all, familiar to you all. So I won't belabor this since we took up most of my time trying to figure out my PowerPoint problem. But you all are very well versed in traumatic brain injury, and especially the different types. So, acquired brain injury, we're looking at stroke, anoxic injuries, hypoxic injuries. But this conversation is going to focus exclusively on traumatic. So when we talk about traumatic brain injury, for us, we're looking at anything external and external damage and external force. And it's also something that we think about as being a point in time. Really consider that when we're looking at the military population and the different circumstances that many of these service members find themselves in when they might be exposed to, let's say, a head injury. And so, the common things that we look at: loss of consciousness, memory, and the time duration for that memory loss. And we've got the different grades of and classifications for brain injury: mild, moderate, severe. You all are very well versed in this, so I won't go into much more detail on that. When we work with our military population, they'll tend to hear, a concussion, a penetrating injury. They're not as familiar with a DAI or a diffuse axonal injury. So when you look at maybe a blast exposure in the field, you'll see some torsion, some torque that's really applied to the brain that causes it to twist, and then you get the shearing of many of those axons. So these are just some things that when I'm normally giving this overview to individuals who are not familiar with the physics and the dynamics of a brain injury, I'll go into more detail. But as you all are very well versed in this, it's much easier for me to just keep on moving and really try to paint the story as it relates to the military and veterans. Traumatic brain injury, in the United States, and I think I'm taking a little bit of liberty. We're looking at possibly 1 to 2% of our population has sustained or is living with a particular brain injury, primarily on the mild brain injury side. Some of the causes of injury, as you all, again, are familiar with: falls, motor vehicle accidents, assaults. And what this really means is it basically tells us that the prevalence of a brain injury, or individuals living with symptoms that are consistent with a head injury, is that it's all around us. Many of us on this call have probably experienced a traumatic brain injury. The cost of a traumatic brain injury, it's quite expensive, in the order of billions of dollars, and that's even that it's inclusive of the cost of to your employer if you're not able to work because of a head injury, and looking at hospitalization costs as well as acute care. They're astronomical, on the order of billions of dollars. So what this really amounts to is that, yes, there's a high prevalence. We see a relatively consistent incidence, mostly related to sports, falls, motor vehicle accidents. So this is, from a public health perspective, a very important issue that is costly to society. Now, you might not be familiar with some of the military side of brain injury and what we're realizing and witnessing with the military population. You see 4 pictures in front of you. I think at least one of those or 2 of those are very familiar with you. When we look at what happens with a military population, several things come to mind. One of those being what's been presented in the media: IEDs, improvised explosive devices, a vehicle rolling over an IED, exploding, causing chaos, causing injuries, amputations, polytrauma type of events, and that's quite well documented in the media, especially with our last few conflicts: Operation Iraqi Freedom, Operation Enduring Freedom, and then the operations we currently have in Syria as well. But what you may not be familiar with is that if we look at the upper left-hand corner here, the use of heavy artillery, firing these weapons, firing these shoulder harnessed weapons as well, those result in low-dose exposures to blast or concussive forces. So when you're training, when you're actually engaged in combat, firing all this weaponry, and it's very heavy weaponry, does expose you to some of these blast forces. Though in low dose, we do have to consider the cumulative effect of this type of these types of operations and these types of activities. Then you'll also see this Humvee here. And I explained to you, the IEDs, the explosions. However, when you're operating in an austere environment, if you're in the desert, if you are training, you tend to not have your adequate sleep, poor nutrition is quite prevalent. And what happens when you're not sleeping well, you're not eating well, you're not hydrating, you tend to lose focus. Accidents happen. So what we do see a lot downrange, and what we do see a lot during training are these accidents with vehicles. So more of like your traditional motor vehicle accidents. We also see individuals who sustain injuries from some of these heavy artillery, heavy equipment. So we see a lot of brain injuries associated with that as well. Not as glamorous or not as newsworthy as an IED or even an RPG, a rocket-propelled grenade, coming at your vehicle, but you do see this a lot, so the training accidents. And then in the lower quadrant here, we see, this is known as breacher activity. So when you have either special forces units or certain units that go in and infiltrate and penetrate a building, they're blowing that building up to get into it. So they blow out the doors and then they push forward and really do what the mission entails. Please note that they do this repeatedly. They do this during training. They do this during actual operational exercises. And again, these folks are being exposed to what amounts to low dose blast, but they're also being exposed from a cumulative perspective to a lot of physical force and physical impact to both their bodies and their brains as well. So these are just some force scenarios that we definitely see in the space. So let's take a look at some numbers, some of the public health side of what we're dealing with in brain injury with the military. These numbers come from the what was the Defense Veterans Brain Injury Center. It's now known as the Traumatic Brain Injury Center of Excellence. Try saying that 20 times straight. But what they do is they actually have all the data, they collect all the information, and this is basically surveillance data since the start of combat in 2001, but they actually predated it a little bit to 2000. And here what you're looking at is the diagnosed or confirmed brain injuries amongst Department of Defense service members right now. So
I don't know if I'm the only one, but I can't hear you anymore. Can we hear him? We can't hear you anymore, Dr. Balbir. Is he not hearing me either? Let's see here. Thank you. Sorry, I'm trying to, Alex? I don't know how to stop him. Let's see.
I wonder if you wave, if he'll see you wave in the screen.
Trying to do that. It's so weird that everybody else, that we just all of a sudden lost him. Oh, he's taking a drink. Maybe he'll see me now. We can't hear you, Alex.
Yeah.
I think you saw it now, maybe.
Yep.
Okay. Thanks, Jen. Oh, maybe. We lost your sound somehow.
Carly, do you have his phone number? Maybe give him a call.
Well, yeah, he's, oh, maybe it's his internet. There he goes. He's connecting to audio now. Can you hear me? No? Oh, you're connected now. Can you hear us?
Well, that was another epic fail on my part.
That's never happened before. I'm like trying to plug you down, but
yeah, I see somebody waving at me, and so yeah, didn't know my phone went out, so I was just having a good conversation with myself. So so thank you all for flagging me. Where did I lose you? This slide?
No, you were on the. You were yeah. You had yeah.
Okay.
You had kind of been just maybe a minute into this one. So.
All right. My apologies. Technical difficulties all around. I own this, and sorry about that. And I didn't even see the chat bar at the top here. So so
yeah,
thank you guys for
and then Jen's like flag him down. So.
Thank you guys for your patience. I appreciate that. So so that's the end of my talk. We're all done. You guys missed everything. Just kidding. I got a few more slides to go. So what you're seeing here is 80% of our service members who sustained a head injury, mostly of mild traumatic brain injury, and then the remaining being more of the moderate to severe. And what I also want to show you guys is that we're looking at over 400,000 brain injuries that were diagnosed in a population of about 5 million service members. So the prevalence of this in our population, in our military population, is significantly higher than what we see in the civilian world. And that sort of makes sense because of the occupational hazards and the issues consistent with combat. So again, we know brain injury is a significant public health issue for anyone, but it's also even more significant for the military population just because of the risk that they take with their occupation. This is also a really interesting slide that came from the Department of Defense. They stopped updating this, and I'm glad I still have a screenshot of what this was. So if you look at when combat operations originally started, you can look over the course of 10 plus years and look at the incidence of brain injury in the military population. And these are all consistent with our Operation Iraqi Freedom and Operation Enduring Freedom primarily. And what you see is this, and we'll focus on that yellow curve right there. That's the mild traumatic brain injury. Does anybody on this call know what happened around between 2005 and 2006, why you see that spike there? Anybody want to take a wild guess? Anyone want to take?
You can type in the chat or you can just talk.
Yeah, please do.
Would that be like Iraq?
I don't see, let me see the chat. No, it's actually a little bit more simple than that.
Diagnosis,
what
they
happened,
were actually looking for it?
Bingo. They were actually, yep, they're actually diagnosing it, and they're actually implementing some changes of care and diagnostics in the field around that time. So, so we're roughly 4 or 5 years into combat. We see this sort of steady increase and then this massive inflection point. There is some research out there that basically is telling us that between around 2003 and 2006, we only successfully diagnosed 1 in 5 brain injuries at that point. So what we missed as a population, or as a military, we missed a lot of the early brain injuries, only to implement some mechanisms to absolutely confirm that there was a brain injury, pull that warfighter out of that situation, and then treat that warfighter. But a lot was missed very early on, and it was on the order of 10 to 20% were absolutely missed during this time period. So, in terms of from the perspective of surveillance, well, we missed out on many years of conflict, and now we've become a much better, more adept at not only diagnosing in the field, but making sure that we are monitoring this clearly for us to survey for treatment, diagnostics, and also getting a better forecast as to what the actual need is in this population. So we've talked primarily about brain injury. I'd be remiss if I didn't talk about post-traumatic stress, especially in the military. And what we see here is that, and I'll train your eyes to the two red circles in there. What we do know in terms of the prevalence and the incidence of post-traumatic stress, that it's relatively high in this population. We're projecting an annual growth rate of 7.5% new post-traumatic stress diagnosis. This is annually, and that's on top of the current fairly large prevalence that we're realizing in this population, which right now stands at about 13%. If we look at just the civilian population, this is almost double. And in some instances, or some reports that I've read, prevalence of post-traumatic stress in this population could be on the order of 30%. These are just diagnosed, and we also are witnessing a fairly substantial incidence of this. 7.5% newly diagnosed cases year over year in this population. So we've got traumatic brain injury, we have post-traumatic stress, and we have, and we have to take care of these service members and their families. So it's a fairly large population that is at risk for, for some really significant issues into the future. So I wanted to highlight this, though we're talking specifically about brain injury. This is what we're realizing from what's considered the signature injuries in our post 9/11 population. Some folks may ask, well, how's it different than previous warfighter generations? Well, our medical capabilities are outstanding now, and they weren't as great maybe during the Vietnam War era. They were not as great during the Korean War era, and definitely not as great during the World War II. But there is a very high likelihood that what we've seen throughout all of those conflicts, we're going to witness very similar long-term consequences for this population as we did with the previous populations. However, one critical factor here is that our ability to deliver combat casualty care in the field in this warfighter generation is unparalleled in any previous era of warfighters. Our survivability, decrease in mortality has been tremendous, and this is primarily due to our expert medics, our expert corpsmen, and our expert clinical staff that's actually been able to save so many lives downrange as a result of these injuries. So folks are surviving, but they're also dealing with a traumatic brain injury, and they're dealing with post-traumatic stress at a rate that we haven't seen in previous warfighter generations, or at least it hasn't been diagnosed as it has now. When we talk about post-traumatic stress and traumatic brain injury from a clinical standpoint, the confluence of these symptoms is very, very challenging for any physician to tease apart. And you're looking at this Venn diagram here that, again, there are specific symptoms associated with brain injury, and there's specific symptoms associated with post-traumatic stress. And then there's there's the stuff in between, primarily around the sleep disorders, cognitive deficits. So brain injury plus post-traumatic stress are very difficult to diagnose, but also very difficult to tease out what's what, because that's really important. As you all know, the treatment strategies associated with traumatic brain injury are different than what we would pursue with somebody who's dealing with post-traumatic stress. But for the warfighter, teasing apart the brain injury and post-traumatic stress becomes very challenging. Adding in a few more layers on top of this, you have pain and pain, traumatic brain injury, and post-traumatic stress, all converging on that one service member. Very rarely would you find just someone who sustained a brain injury. Those are very hard. You don't find those patients very often in the veteran or the military population. But what you do absolutely see is predominance of and clinical presentation for both brain injury, pain, and post-traumatic stress. So adding on these different layers and these different adjustments that clinicians and the clinical community has to manage becomes extremely challenging. Just think about the pharmacology that's associated with treating a brain injury, treating pain, and treating post-traumatic stress. There are many contraindications for those meds as they relate to pain management, seizure management, but also with cognitive deficits. So this, the moral of the story here is this is these are very challenging clinical symptoms to deal with, and very seldom do you see brain injury or post-traumatic stress or even just pain as solo individual diagnoses for a veteran. They generally have all of these. Now, we talked about what happens, what we're seeing in terms of the public health, the numbers, and the clinical presentation of these warfighters. But now we tend to forget that the field of brain injury, though we have classic cases, let's say in sports and boxing and those combative types of activities. We've seen what happens with some of these individuals, but now we're really understanding better what happens to the military community when they've sustained a brain injury, and we're starting to realize the significance of these wartime and these operational brain injuries on the long-term future of these veterans and their long-term health. Traumatic brain injuries, specifically mild traumatic brain injury, repeated head injury, has definitely been associated with chronic traumatic encephalopathy. So CTE, you hear about this on the news with football players, hockey players, boxers. They have and present with CTE. The big issue here with CTE is it's a post-mortem diagnosis. And we're also seeing this in our military population. Parkinson's. Studies have shown that mild traumatic brain injury raises the risk about 56% for developing Parkinson's. So we're looking at some very serious neurodegenerative conditions that are presented in this community that we may not see in our general civilian population. All this being said is that we have to understand this better in order to provide better clinical care, better long-term care and long-term care planning for the clinical needs, as well as the home and community-based needs as well. And when we look at post-traumatic stress, elevated risk for hypertension associated with post-traumatic stress, the good thing about studies like this is that we've realized that if you treat the post-traumatic stress, you can actually decrease the hypertension in that patient as well. Can't say the same for brain injury. It's something that we're still learning a little bit more about, what treatments sort of ameliorate some of the symptoms associated with brain injury. But we're seeing that with post-traumatic stress, though you have a higher risk of hypertension, we can remediate that through gold standard treatment for post-traumatic stress. Other comorbid conditions also are consistent with post-traumatic stress, and then cardiovascular disease. So we're looking at sleep disorders, diabetes, smoking, drinking. These are all associated with post-traumatic stress, and they're also associated with traumatic brain injury. All of those factors contribute towards elevated risk of cardiovascular disease in this population. So we talked about brain injury, we talked about pain, we talked about post-traumatic stress, and then you start to add on all these other factors in here that really, this goes far beyond the brain injury side of it now, and now we're looking at cardiovascular disease as well, because of these other comorbid conditions that really sneak in and really decrease the quality of life of an individual and make them more susceptible to long-term health risk and health consequences. So that was sort of the bigger picture of the military population and the veteran population. I'm going to talk to you a little bit about what we're doing at Wounded Warrior Project, and I'll touch on a couple of our programs, but I wanted to show you that when we look at the larger population and we see that the prevalence is there, the risk is there. At Wounded Warrior Project, we actually work with individuals who, it's a much more concentrated group, and folks who are presenting, and I'm going to show you this very brief, I'm going to show you this soon. They're a group that self-selects to be part of our program, but their issues that they're reporting are even greater than what we see in the general military population, and far greater than what we see in the civilian population. So here I'm showing you some data from our annual Warrior Survey. We've been doing this for 10 years now. We have over 100,000 individuals who are registered with Wounded Warrior Project. Those individuals, we send them a survey, and we get anywhere from like a 25 to a 40% response on those surveys. They talk to us about their healthcare needs. They talk to us about what symptoms are troubling them. We embed certain assessment tools in there as well. And I'm going to show you some of the data that we have from our most recent annual survey. 6% we have are active duty. We do work with a lot of active duty, not a lot, but a small portion of active duty personnel who are seeking care. 47% have deployed 3 or more times. So the individuals who self-select for our programs, they have been at the greatest risk because of their because of their deployments. And 92% of the individuals we work with not only deployed, but they deployed to at least once to a combat zone. And when they report back to us, it's quite alarming. And these numbers have been consistent for 10 years. And by consistent, I mean they haven't gone down. They've been actually increasing. But it is truly an indication of the prevalent issues that these veterans are facing. No surprise, sleep issues are reported as some of the highest issues that they're dealing with regarding their health. Primarily insomnia, also issues with sleep apnea as well, due to medication or lack of physical activity. They're also dealing with post-traumatic stress, about 83%. But then you have depression, and then you have musculoskeletal issues as well, which are also consistent with the reporting on pain as well. So that 74% that you look at back, neck, shoulder problems, we also know that about 80% of them are dealing with pain. 33% have or require aid and attendance from someone else. So again, this really highlights the magnitude of the need, and the individuals who come to Wounded Warrior Project who are seeking our programs, or programs that our partners deliver, because there is a need for this, and they are truly sick and dealing with some significant issues. And if you want to, and here we're categorizing the level of more brain health needs. Post-traumatic stress, as I said, highly prevalent, 83%. Nearly 40% are dealing with symptoms consistent with a brain injury. Again, much of this is self-report, but when they report on their brain injury, about 4 in 10 individuals report symptoms consistent with or have had a diagnosed traumatic brain injury. So within our walls here at Wounded Warrior Project, the need is great, and this is actually where we direct many of our programs to. Based on what is reported during our annual Warrior Survey, we can pivot our programs, build programs, fund programs that really do address these needs. I'm going to stop. Does anybody have any questions? I've thrown a lot of data at you, clinical, public health type of stuff. If you have any questions, please do feel free to ask. I'll take silence as we'll keep on moving forward here. Okay. So now we're going to move into some of the things that we're doing with our partners in the space to address traumatic brain injury. We're looking at clinical care, rehabilitation, diagnose or novel diagnostic capabilities. But I'm going to focus specifically on some of our clinical approaches here and what we're doing in the space. One particular group that I want to highlight is a group out of Boston, out of Massachusetts General Hospital. Some of you may be familiar with them. You may have sent some patients over to their Spalding rehab facility. We partnered with Home Base about 4 or 5 years ago. Home Base is the military and the veteran family program that's associated with both the Red Sox and Massachusetts General Hospital. We funded Home Base to develop a 2-week intensive clinical program for traumatic brain injury. If you look at, especially in the military population, it wasn't until, I would say, 2009, 2010 timeframe where the military actually made the decision to start to develop some brain injury-centric programming. And we found that those clinics that focused exclusively on brain injury as well as post-traumatic stress were very successful. These were intensive clinical programs that were developed by the military. Many of these service members, they don't have time to really engage in months or even years of rehabilitation for their traumatic brain injury. And especially when we've invested millions of dollars in their training, what we hope to do is find them a program or build programs that would provide them with a year's worth of treatment and diagnosis in the span of a couple weeks. And we developed with Home Base a program that would do such. So it's their 2-week intensive outpatient program, or we actually call it the intensive clinical program, which really brings forward an interdisciplinary approach. The veteran and their family members are brought to Boston for this care. This is all free of charge to the veteran. So no veteran pays for transportation or treatment in this particular program. And when they're at this program, they're basically getting every possible every possible service line that works in traumatic brain injury as well as in mental health. They're getting access to it. But we're also following up with them once they discharge from that program after they've graduated in 2 weeks. To give you an understanding, this, and I apologize if it's so small on your respective screens, I apologize for that. But they're basically getting a very heavy dose of rehabilitation and treatment, as well as diagnostics in that whole week. Now, the clinical piece of what they're getting is just the backbone. They're also getting additional supports and services, recreational therapy, occupational therapy. They're also getting some alternative therapies as well, art therapy, music therapy. So adding all of that together in a 2-week time frame really does prepare the individual to then go back to their home and community with a really nice care plan for their at-home, for their physicians and their clinicians at home. So this gets the individual going on their treatment plan. Please note that many service members who've left the military, many of them have not received a proper diagnosis, nor had they received a proper care plan. And many of them believe to be, once they left the military, that everything was fine. They might be getting certain services from the VA, but turns out they may not have received an appropriate diagnosis nor an adequate treatment plan. So this program here really does provide individuals with a significant amount of services in a small time frame. This is just some data looking at outcomes. We're always measuring outcomes in any of the programs that we have here at Wounded Warrior Project or through our partners like Home Base at Massachusetts General Hospital. When you look at pre-treatment for these 5 measures, some measures you probably are familiar with, NSI and PHQ-9. The pre and the post assessments are, it's night and day. The significant improvement in symptom reporting, as well as mental health reports such as PHQ-9, really shows that the work being done in 2 weeks clearly is effective. You're probably wondering, well, what happens 3, 6 months out? I can tell you that the data for 3, 6, and 12 months out, no one ever returns to the level that they came into the program with. In fact, once they hit those lower, the lower symptom reporting, let's say in the NSI around 28, it's consistent for 12 months. And we're starting to look at, the outer years as well, 24, 36 months as well. But this clearly shows that an intensive clinical program not only is effective in the 2-week span that they're there, but the results stick. And that's also consistent with the fact that the case managers, the social workers still remain in contact with these patients once they discharge. That's something that we absolutely believe in as an organization, to maintain that continuity of care. Though you're not in Boston anymore, you may be in the great state of North Dakota, but everyone is followed up with in our programs, and that's really important, as you all are aware as well.
So we did get a question in the chat. Does this program have to be completed within a certain time frame of their TBI?
No, and that's actually a really good question. It's very rare that we get someone now who is an incident trauma case and goes into the program. Many of the warfighters that we're working with right now, it's been years, 10 plus years. I mean, we're in 19 years of combat right now. And many of the cases that we see are from those time periods that I showed you very early on, 2008, 2010, up to 2015. So, 12 years ago, 5 years ago, 10 years ago, these are the cases that we're dealing with. These cases that have been, refractory to current treatment protocols. So there is no, we have no limit on when you sustain your injury, the time of injury to when you're seeking care. We'll work with any of those folks.
Thank you.
You're welcome. And so another program that we've developed with our partners at home base, Massachusetts General Hospital, is the Comprehensive Brain Health and Trauma Program. This program is actually directed specifically for the special operations community. Some folks may think maybe taking a treatment program that normally is delivered over the course of months, putting it in a 2-week program for an intensive clinical program is challenging. For this particular community, we looked to develop something that would consolidate a lot of that treatment into a 4 to 5 day window. Most of these individuals in the special operations side, so you're looking at Navy SEALs, Army Rangers, Green Berets, Delta, those folks who the government has spent millions and millions of dollars on. They tend to present very well while they're on active duty, but unfortunately, once they leave active duty, things become very challenging for them. So these programs were developed not only for the retired special operations community, but also for the active duty community. What we do in 4 to 5 days is a comprehensive program that focuses on diagnostics, treatment planning, and then also we're introducing some treatment as well for these individuals. Really, the goal here is to help get those who are on active duty, get them back into the mix. Really try to overcome any challenges they've had associated with their brain injuries. These are what we call the high-speed special forces teams, the ones who are breaching, the ones that are using heavy ammunition. And they tend to be the ones who are most at risk for some of the more significant neurodegenerative conditions. So any opportunity that we can get to support them, to help better diagnose them, and then discharge them with a care plan that is executed in their home and community. This is really important. You'll see the little hub and spoke model there, really talking about all the different types of services. So this is 4 to 5 days compared to the 2 weeks that we provided in the previous example. Pretty remarkable what you can do. And some of the early data that we've seen in this program is that it's become very effective in terms of reducing some of the symptoms that these special operators are dealing with. Truly an innovative type of program that's geared towards specific individuals. I don't know of many individuals who even want to go for intensive clinical treatment in a 4 to 5 day span. That takes that significant gumption to want to be a part of this, to really immerse yourself in that treatment, both from a brain injury perspective as well as from the perspective of mental health care as well, because they are getting some neuropsych evals as well as treatment in there. So this is intense, but what we find that it's actually working quite well in this particular community. So now I'm going to talk briefly about our some of our home and community-based programs. I can safely say that this group here on the call understands that when clinicians within a fixed facility decide, here's your care plan, and that patient walks out the door, chances are that care plan is out the window as well, unless it's monitored, unless there's good compliance. If there's a caregiver or caregivers involved, it becomes very challenging once you leave that fixed facility. This was sort of the impetus behind the Independence program. We developed this program because in those early years of combat and when folks, service members returned, when they returned back to their homes and they were discharged from either the VA polytrauma centers or from the Department of Defense military treatment facilities, we saw that though the care that they were given in the hospital was outstanding, they needed more in the community. And so we built this program called the Independence Program, and it's specifically tailored towards individuals with a moderate to severe brain injury, spinal cord injury, or individuals dealing with some of the neurodegenerative conditions that I discussed previously. And they tend to be consistent with undiagnosed brain injuries or diagnosed brain injuries. So you're looking at Parkinson's. We've worked with patients with MS as well. So this is what we designed the program. This is who we designed the program for. So the Independence Program was basically, independence is relative to each individual, and this program really affords individuals the opportunity to learn, to improve their quality of life at home. And what does that really mean? We're looking to have those individuals rely less on a caregiver. And we're also looking for these individuals who sustain these catastrophic injuries. We're looking for them to avoid being transitioned into a assisted living facility, avoid being transitioned into more of like an elder care type of institution, because the warriors that we work with right now, they're in their 40s, but yet the only facilities that are suitable for some of these individuals, they're generally geriatric care type of facilities, and we don't believe that that's appropriate for this for post 9/11 veterans who've been injured, in the line of duty, and then obviously our goal here is to create and improve that quality of life, both for the veteran and his caregiver or her caregiver. Just to give you a sneak peek as to who we work with in our Independence Program, a majority of them have, service-connected injury. This was either during training or in combat. 77% have a caregiver. And you'd be surprised, those living with a moderate severe brain injury, associated with their military career, many of them don't have families. And they really rely on themselves or organizations like Wounded Warrior Project or other veteran service organizations to really keep them alive and active in their home and community. We've measured risk, looking at maybe 34% are at risk of institutionalization. That's generally due to their cognitive issues, physical issues, safety issues associated with their current medical or physical state. So we have folks at risk, and with the loss of, let's say, their caregiver or some other service that's being provided to them, those folks are the ones that I just previously discussed who would be more likely entered into one of those facilities that's just not appropriate for this generation of warfighter. Some of the medical conditions that they're dealing with, most have been diagnosed with a moderate severe brain injury, and many also, the comorbidities of this are devastating as well. So it's not just the brain injury. We have a saying on our team that a brain injury is kind of like the hangnail, right? The mental health piece is the one that sometimes becomes very, very challenging for us to deal with, especially those who may not have additional supports and services like a caregiver or a family around them. So that mental health condition drives them towards, behaviors that are unsustainable. We have spinal cord injury as well. So all of these are consistent with some of the more they're consistent with the injuries that we've seen on the battlefield that I showed you very early on, the traumas, the explosions, the IEDs, RPGs. So these are the folks that we work with in our Independence Program. And currently we have about 700 individuals enrolled in this. But if you looked at the first slide one of the first slides I showed, there's thousands and thousands of individuals who would likely qualify for this program, but we're either not getting in touch with them or these types of programs. And I'll show you sort of the meat of this program right now. what do we do? It's basically our model is what would be considered more of like a wraparound model. We're looking to provide that continuum of care. So when you discharge from the hospital, when you're now in your home and community, providing those additional supports. We have an internal staff member, an independence program specialist, as well as a dedicated community-based case manager working with each of these families to make sure that they get to their doctor's appointments, to make sure there's services in place, provide that safety net for those individuals. And that's quite critical for this population. And we also provide what we call our community support specialists, which is very similar to a life skills coach, but a little bit more of a souped up life skills coach. Think about occupational therapy, CODAs, those types of folks. We actually provide those types of individuals to our warriors in our program to set goals, their physical goals, social goals, volunteering type of goals, anything that would help them become more involved in their communities versus remaining isolated in their homes because of their injuries. We also provide some additional services, so additional CAM, complementary alternative medical services, equine therapy, art therapy, music therapy. You'd be surprised that with a very tough exterior Marine, soldier, airman, sailor, they gravitate towards these services very, very quickly, especially the equine therapy. Tough Marines, they love these different alternative practices. They prefer not to go to their mental health provider because it's more clinical, but we also trick them a little bit by giving them these types of services, and they're actually quite therapeutic for them, and they're done in the presence of therapists as well. So these types of treatment modalities are very, very effective in this population. And we also provide some of those other services that you normally don't think about being associated with, as part of a clinical care approach. Transportation. We have someone who's on on medication. Those individuals, they can't drive to their doctor's appointments, or who've had their driver's license revoked because of the medications that they're on. These individuals, we make sure that they get the transportation that they need. We will pay for that transportation to make sure that they are consistent and compliant with the care from their care team. What's the impact that we've seen? And these are just some observational statistics that we have here. Our warriors are very satisfied with the care that they get, that we provide them. We try to, like I said, support these individuals with more home and community-based services. We will, however, pay for clinical care where needed. There are instances where some folks that we work with have an injury that they sustained that was not service connected, and therefore they may not be getting the VA entitlement. So we will provide home health aid, skilled nursing, those types of services for those individuals as well. So that's important that we help bridge the gap for some of these folks, because the alternative is usually one of those housing facilities that's just not appropriate. We've delivered nearly 200,000. This was all last year. And so I haven't updated our numbers here on this, but 190,000 hours for 700 individuals, community-based support, that's case management, alternative therapies, occupational therapy, rec therapy, for 700 individuals. And we're happy to report that most of the veterans that we work with in our program, they're all supported in their homes and communities. So we do believe that we're mitigating some of these risk factors that would lead them to wind up going into a facility. And so this is really important as well. And we've also seen improvement in their resilience. So when we measure resilience scores in these warriors. We do see significant increases, year over year with their resilience. So the services that we are providing do improve their, we do see improvement in some of these clinical tools, clinical assessment tools. We just wrapped up talking about some of the clinical work that we do. I discussed, our initiative with Home Base and the clinical model that they have, both for traumatic brain injury, their intensive clinical program. We discussed their special operators program as well. I talked specifically about our home and community-based program, the Independence program. Now I'm going to talk about very briefly some of the work that we've done with some of our partners in the space, primarily for outreach, education, and also some policy as well. And one of those programs I'm going to talk about is Project Enlist. It's a program that we've supported through a grant with the Concussion Legacy Foundation. Some of you may have heard about the Concussion Legacy Foundation. So Project Enlist is one of their programs specifically tailored towards the military population. Concussion Legacy Foundation, they were basically, they were born out of the need to get to understand brain injury, to educate the population on brain injury, specifically focused around the development of CTE in athletes. But as soon as the data started coming around looking at the veterans and military personnel as being significantly at risk for developing CTE, they started to expand their reach a little bit more to the veteran population. And that's when we partnered with them to help them realize the goal of improved education and also increase and expedite some of the research that's going on for a CTE in the military population. Their leadership, Dr. Chris Nowinski and Dr. Bob Cantu, both the founding members of the organization. Chris on the left there. Chris was a former football player and former WWE wrestler as well. Tall human being, 6'5", but then he also went on to get his doctorate in behavioral neuroscience. But, being a football player, being a wrestler, someone who's had to overcome traumatic brain injury most of his adult life, this is important to him. Though they started their journey focused on professional athletes, which we hear a lot about, they really became interested in the military population over the last couple of years, and we're proud to partner with them for this. What is it exactly that we're trying to do with Project Enlist? Well, we're looking to expand the brain bank. So getting veterans to donate their brains for research sounds absolutely morbid. Very tough subject to breach with veterans, very tough subject to breach with somebody who's currently alive, but may have sustained multiple traumatic brain injuries. We want to encourage individuals, those who have served our country, we want to encourage them to make that commitment to donate their brains. Unfortunately, what we see too often is individuals who've taken their lives because of traumatic brain injury and the mental health consequences associated with it. They may not, we have very poor diagnostic capability for CTE. And when they take their lives, unfortunately, we don't have enough brain tissue to work with to really use that tissue. But if you do, if you are a member of Project Enlist and you donate your brain, if you are a donor, it pretty much offers us an opportunity that when you do die, gives us an opportunity to evaluate your brain and really understand better the natural history of brain injury and the development of CTE. And so we are encouraging folks military personnel to donate their brains, early, donate them now, make that commitment to do so that we learn more about the injuries you've sustained, the issues that you're dealing with, to hopefully help improve our diagnostic capability in the future, but also hopefully we can prevent some of this from happening to future warfighter generations. It's really been a great partnership that we've had with them, not only to elevate the voice of the veteran and bring awareness to the issues associated with traumatic brain injury, but to also get these individuals to commit to the future of brain health. This is just a slide that we have that shows where you can find some information to donate your brain. I am a donor. I've donated my brain several years back to this, and my wife is very proud that I donated my brain to help, just like when we are organ donors as well on with our driver's licenses at the Motor Vehicle Administration. ProjectEnlist.org is where we can find some information. There's my two colleagues here, the upper right, who serve on the board of Concussion Legacy Foundation. I also serve on their advisory board as well. Dr. Van Horn and Dr. Hines, psychiatrist and neurologist, respectively. We're all in this fight together to bring greater awareness to brain injury and specifically CTE in our military population. What else do we do in the space? As I mentioned earlier when I kicked this off, clinical care, research, understanding the public health issues associated with brain injury, very important. But unless those lessons learned, unless that best practice becomes translated into a standard of care or translated into better policy, we're really not doing anything to benefit our future. And here, what I'm showing you here is we have two major brain health initiatives at Wounded Warrior Project, and we're looking to improve the continuity of care for those individuals who've sustained a brain injury. As you all are aware of, the continuity of care in this field is very challenging. Despite many of the veterans that we work with having access to VA care, the continuity of care itself still leaves a lot to be desired as they work with VA providers, home and community-based providers, but that continuity of care is extremely important. Navigating federal and state resources also remarkably challenging. So that's one of our initiatives for this year, and then also preparing for the long-term care needs as this population gets older, as they're dealing with these chronic neurodegenerative conditions, which they likely will develop over the next 10 years, making sure that they have planned for the future, making sure that the most appropriate facilities are available to them, and the types of rehabilitation and care is available to them. That's our second priority. And one thing I did want to highlight here is that we supported and endorsed the Commander John Scott Hannon Veterans Act, which specifically for the TBI community really is looking to enhance both research on precision medicine associated with brain injury. So the movement is there on the policy side to really develop those clinical best practices and distribute those practices to the greater population, so that we're not only focused on a handful of best in class facilities. We want to make this accessible to every individual, not just veterans and their families, but also to everyone, because brain injury does impact a lot of individuals, not just the military personnel. Future initiatives that we're looking at Wounded Warrior Project. I spoke specifically about the veteran journey, the service member journey. We are deeply committed to improving the lives of caregivers as well, especially those caregivers who support individuals with a traumatic brain injury. We have some initiatives in play right now where we provide mental health care to to caregivers of those individuals in our independence program, providing them respite care, providing them, just the ability to engage with one another. So we're looking to enhance those programs related to caregiver well-being, because caregivers are the support system, the backbone for these veterans who've sustained these catastrophic injuries. We're also looking to enhance our portfolio on research, novel treatments for traumatic brain injury, to include transcranial magnetic stimulation, non-vagus nerve stimulation for migraines and headaches. Very important to get these new tools in the hands of these veterans, because it is important, and not all the clinicians and providers out there are really up to date on some of these more novel treatments. So we're looking to really advocate for some of these treatment modalities to be put into the hands of veterans. And people always ask me why I do what I do. I serve myself. It's my family there. When I raised my hand, my family came with me. What we talked about, brain injury and mental health, doesn't just impact the veteran, it impacts the family that's around them. Without our families and without that sisterhood and brotherhood that we have within the military, we don't have that bond, but that bond is there between all of us, between our families. And I took an oath to take care of my brothers and sisters, for my career, and that's what my career has taken me to. And that's really why I do what I do, and also, beat Army, and that's important as well. So that's it. Anybody have any questions? I went through a lot of material. Hopefully it was engaging, but I'm happy to address any questions y'all may have.
We got one. Some of the veterans I support suffer from migraines. What can I do to help?
Yeah, that's a, headaches, migraines, quite common in this population. I talked about one specific treatment modality, and that's the non-invasive vagal nerve stimulation. Fairly new type of technology that's out there. It's available through the VA to treat individuals who are dealing with a migraine. And one thing that I do want to stress with migraines is that, you want to get an appropriate workup with a clinician who specializes in these headaches. The headaches could be for a variety of different reasons. So you want to make sure that someone who is suffering from migraine, you want to make sure it's not something else, not something more serious than migraine. It's likely, I've seen a lot of these migraines due to brain injuries, undiagnosed brain injuries. So I would encourage those individuals who are suffering from migraine to really identify a specialist in migraines, and really make that appointment and go talk to them, but also ask them about non-invasive procedures, non-pharmacology-based procedures as well. Very important that that veterans understand that treatment doesn't always have to be through a pill. There are other methods out there that are showing some promise to resolve headaches and pain as well.
How has the COVID affected your independence programs as far as like the volunteering and those pieces? Are you still able to do a lot of that, or?
Oh, well, a lot of our programs here at Wounded Warrior Project have seen some impacts to COVID, but we've also realized some opportunities here to move our programming virtually. You'd be amazed what you can do virtually, especially from maybe an occupational therapy perspective. Technology is great these days. You just need Wi-Fi, a tablet, and you can do a lot of stuff. Our music therapists, our art therapists have been able to continue to provide these types of services remotely and virtually. It's been quite remarkable, and it's also been a great opportunity to get families involved at the same time. So having that spouse, parent, caregiver, whoever that may be, participating with you and with the music therapist or the art therapist, that's been a remarkable, it's been a remarkable set of services, and we've been able to adapt to that. We do unfortunately have about 20% of our population that we work with in the independence program, their services were suspended because of coronavirus. As great as virtual programming is, it still confines those individuals to their home. And, as I mentioned, and as you guys know, getting out in the community, getting out, building that social capital, building that social currency with these providers is of the utmost importance, and bringing people together is important. So you have a trade-off there, and I think we're also excited to get over this coronavirus pandemic as quickly as possible to reinstitute these services to these families, because it also closes the world in for that caregiver as well. That caregiver too cannot shed his or her identity while remaining in the home isolated because of the pandemic. So we're handling this on a couple fronts, but learning a lot of lessons, as you all are as well, learning some lessons on how to manage during this time of a global pandemic. So we are prepared for the next pandemic, whenever that may be. Any other questions?
Is TBI a career ender for service members? Do you find that service members and veterans are hesitant to self-report due to a concern that it might mean forced separation?
That's a fantastic question. There's two things that in your military career, if you do sustain any type of injury, two things that you have to be concerned about. A is, can you become physically fit? So let's say you break your leg and you are a special forces operator, and you break your leg, but yet your strength is decreased. You can function perfectly well, and you've recovered clinically very well. But your command says, no, you're not as fast or agile as you were. We can't bring you back onto the special forces team. And you've been trained to be an operator. And the last thing you want to do is go back and work at a desk or work in operations. And so we have to weigh the issue of, are you medically capable of continuing with your military service? And are you appropriate for the job that you had signed up for? And those two may not align, and that becomes a challenge. So with a brain injury, we have to make sure you're medically cleared to continue going. But if you have some issues after your brain injury, let's say with mobility and gait, you may not be suitable anymore to continue on with your service, and then we have to move towards medical retirement. To answer that second question, the best examples of not reporting your brain injuries, we do see those in the special forces community, where after repeated exposures, repeated breaching, repeated combat tours, they appear fine, both physically and mentally during their active duty time. And then as soon as they either retire from the military or separate from the military, all bets are off. It's just a whole world of diagnoses that were either disregarded, clinical conditions that no one paid attention to. So it becomes very challenging for us in this community to try to avoid, to try to mitigate this stigma that it's okay to get help now, report your injury, but there are consequences if you do report your injury, which may not align with the command. But we first and foremost want to make sure that you get the care that you need. That's the most important part, for you to commit to care despite the stigma associated with it. And that's really what we want to get to. If you don't get that care, your likelihood of even remaining in the military it gets smaller, because these symptoms will start to present, and that's when folks get in trouble. And we do believe early intervention, as you all are familiar with, early intervention is key here. Early diagnosis, early intervention, early treatment is really, really critical. And we hope that that level of commitment by the commands to allow these folks to get care that they need will hopefully lead to a long career within the military, where appropriate and applicable.
Excuse me, has anyone ever compared the suicide rate between military folks and civilians?
Military and civilians? We're seeing somewhere between 7 and 20 suicides per day in the military veteran population. It does lean a little bit towards the older veteran. The comparison, I'd have to go back and look. The risk factors from military service seem to be, there seem to be more risk factors in the military for suicidal ideation and suicide completion compared to your regular civilians. If you just look at just mental health alone, post-traumatic stress is we believe to be almost double what we see in a civilian population. So that risk is a lot higher in the military population. Their access to weapons as well. We look at harm reduction. We want to look at securing weapons. Military personnel have weapons. They're weapons trained, so they'll have that. May not be that may be more prevalent within the military population than the civilian. But I don't have the exact number on military versus civilian, but I do know very well that the risk factors for suicide appear to be much higher in the military population and the veteran population than they do in the civilian. And that's brain injury, mental health issues, pre-existing conditions as well. Before they came into the military, we tend to forget about those as well. Coming into the military, what you come in with, pre-existing trauma, pre-existing abuse, anything that would anything that would cause a little bit greater risk for mental health issues, as well as suicidal ideations.
I can almost guarantee that that's what you're saying is the truth. And the reason is because in the military, for the most part, there is a very strict way of doing things. And no longer being able to do that or the same way is pretty devastating.
It is. And that transition, JP, that transition is very challenging as well. We always want to look at two issues that contribute to suicide, belongingness and burdensomeness. The belongingness is part and parcel to being in the military, being in that community. The burdensomeness is when you may separate from the military and you realize that you don't know where your career is going. You just finished serving, you were told what to do, you knew where your orders were going to take you, you had roles and responsibilities. Transitioning out, now you feel like you're a burden to your family. You feel like you're a burden to society. And those things I do believe are very critical in understanding. But you can also apply very similar rationale to non-military personnel as well. Those feelings of burdensomeness, those feelings of loneliness, and belongingness as well. They're quite important. But we do put the military under a bit of a microscope just because of combat, exposure to combat, and then that being the risk. I would also encourage everyone who's even not in the military, not a veteran, to really pay attention to those individuals around you who might be suffering in silence. I think it's very important, and we started to see that with coronavirus as well. The mental health issues are going in the wrong direction because of this. So,
Thank you.
We have another question about, there's an aphasia group at VA that's open to the public. Do you know of any other services open to the public as far as?
I'm not familiar with, I'm not familiar with any other VA groups. I know they're trying to explore more peer-led groups. Excuse me, I was going to cough. They also have more peer support groups, peer-led groups. I believe those are somewhat open, but I'm not positive on all the programs that they do provide that are open to the public. So.
Thank you.
Yep, that's a good point, Amber. Thank you.
Yes, Amber, I agree. Yeah. So Amber put in the chat, just the action of leaving the military, even without disability, can be difficult for servicemen and women.
Yeah, very true.
Wait, before you go, thank you. What you're doing not only helps the military, but there's a heck of a lot that's helping civilians too. So thank you.
Oh, you're quite welcome. And it's a team effort. I consider this a big team effort. It's why we're talking, this could help you all with your next veteran patient who walks in the door. So any opportunity we get to talk about this is important because this is a community effort. It's a public health issue. It's not just a military veteran issue. We're all part of this community, and we do appreciate everything, all the support we get from you all and organizations like yours. So thank you guys. I appreciate it.
Thank you. And thank you for your time. And anybody have anything else for him? Good. All right. Thanks for coming today, and thank you for your time. Nice to meet you.
Thank you for having me, Carly. Y'all take care. Thank you so much again.
Thank you.
Thank you.